I am an occupational medicine physician. That's a doctor who's trained to diagnose occupational lung disease. And I have a background in pulmonary medicine from a previous training. And I'm also called a B reader, in reading x-rays for occupational lung disease. I've been involved with the Libby community and the project and the card for many, many years. And I wanted to show you how we diagnose occupational disease, lung occupational disease, and what is different between the Libby disease and other diseases that we commonly see. The asbestos disease that we see in Libby is very different from the classical asbestos disease that doctors are trained and know to diagnose. And this is the reason why many doctors are not seeing this disease in other parts. And not only that, but the reason why many doctors are denying that this disease exists. And it's very, very dangerous for the people. It's very sad for the scientific community. But this is the story of occupational medicine. We know occupational medicine has had that story for many, many years. You know, workers are exposed to a toxin. They realize that there's something making them sick. They go to doctors. Doctors really have no idea how to put one and one together because they don't get training. You know, a regular doctor in medical school at most will receive 4 hours in his education. In 4 years of medical school, at most will receive 4 hours of occupational medicine. And so docs have no idea how to put one and one together, and they don't diagnose this. The story of asbestos disease in general is very similar to that. There was, you know, this asbestos going around, and docs were seeing people with lung diseases, but nobody was putting that one and one together until some doctors started to say, maybe what people is saying is true. And one of the things we're taught in medical schools is listen to your patients. And, you know, I have to say many docs don't listen to the patients. And in occupational medicine, we learn that the patient is the one who tells the doc, I have this, and I think I have it, and you have to believe me. And when these docs started to put one and one together, they recognize asbestos disease, and that's how it became a well-known disease, occupational disease. That's what's happening in Libby now. We are seeing a different type of disease. We're the ones who are lighting the fire and saying, this is real, this is happening, this is different. Docs in the rest of the United States believe us, start looking for that and understand that this is happening. So let me show you what's the difference. How do we examine the lungs in medicine? And I'm going to talk a little just about what we call imaging. So it's like taking pictures of the lung. There's basically two ways that we examine the lungs nowadays. One is called the chest X-ray, and one is called the chest CT scan. The CT scan is a much more newer technology. It was newer many years ago. Now it's not so new, but every day they're making advances in chest CT scan. The chest X-ray is a simpler technology, but it's a less detailed. So what it does is it takes a picture of your lungs and it puts the lungs in just 2 images. It's like front and back of the chest, and collapses everything together into one picture. It's much less expensive. And we generally use it as what we call the first-line imaging. So when somebody is looking when a doctor is looking for a lung condition, the doctor will order a chest X-ray as the first imaging. The CAT scan is a much better technology. It really is like you know, with all respect to car manufacturers, it's like putting a Formula One against whatever little car you want to. So it's like driving a Formula One. It really gives us a much better ride. A much better diagnosis. It offers, instead of offering just a 2-dimensional view, it offers 3 views. So we can see the chest from the front to the back, from the top to the bottom, and from the right to the left. So we can really see the whole chest. It also uses X-rays, but it takes the X-rays in a different way. It kind of chops your lungs through different ways, and you get slices of the lungs. And then you get a much more detailed view of what's happening in the lungs. It's a much better method to diagnose, for example, lung cancer and to early find lung cancer, and you're going to hear about that in a few minutes about that. Both tests use radiation. The CAT scan uses a little more radiation than an X-ray. So let me show you what an X-ray is. So this is a chest X-ray, and what you can see is, you know, these are the lungs. They look black because everything in the X-rays that has air looks black, and the lungs are full of air. This is the heart, which is full of blood, so it's very, very white. But you see that, you know, that's all we can see. We can see your lungs made into a tiny, tiny thing, and really everything from the front to the back is collapsed into just 2 dimensions. This is a CAT scan, and this is a CAT scan from the old generation. So you can see it goes from the top to the bottom. So this is at the level of the neck, and it goes all the way down to the level of the chest muscles. So from the top, it goes down. You can see from the front to the back, from the left to the right. So you really see in 3 dimensions what's happening in the lungs. This is a kind of almost at the first generation CAT scan when they did only like 50 images in the chest. They cut the chest like 50 times. Nowadays, they can put 25 images of the lung in this little finger. So they do cuts every millimeter. So this is 25, almost 25 millimeters. So imagine how detailed is that they can chop your lungs in 25 times all over the lungs. And that's the beauty of the CAT scan. So it really shows much more of what's happening. We generally blow one of these images and we get this slice of the chest. So these are the lungs. They're black, the same as the X-ray. And this is the heart. But here we can see these white things are the ribs. And next to the ribs is what we call the lining of the lung. That's called the pleura. And you really don't see it because the pleura is a very, very tiny thing. It measures at maximum a few millimeters when it's healthy. And then you see the lungs itself. So a CAT scan can give us much more detail of what's happening in the chest. When we see an X-ray for asbestos disease, this is generally what a pleural disease will show. You see these patches of white tissue. I don't know if you can see them there, but these white patches, which you don't see them in the regular X-rays. See, there's nothing there. There's no white patches there. But that's as much as you can see. This is a more advanced disease, so you can see much better the white patches, but that's as much as you can see. When you put a CAT scan, you see much more detail. So all of these white patches that you're seeing here, they show like this in the CAT scan. So you can see them where they are. You can see these huge bumps of tissue. And this is thickening of the lining of the lung because of asbestos exposure. This is what doctors are trained to do in those 4 hours. So in 4 hours in medical school, if you ask a doctor, how does asbestos look in the X-ray, in a CAT scan, they will say, oh, it's those big batches of white tissue that we see next to the lining of the lung. And that's what doctors think about asbestos. What happens in Libby? In Libby, we're not seeing that. We're not seeing these batches of white tissue. What we're seeing in Libby is a very, very thickening of the lining of the lung. So if you see the edge of the lung, this is the rib, this is the lung, and you see a white piece of tissue there. We see the lining of the lung very, very little thickened. And it's, as many things deceiving, the little you see, the worse it is in Libby. And that is the problem. It's a very, very little thing to see in the X-ray, very hard for docs to see because they're not trained to look at it, but it's very, very damaging. This disease is much worse than those big blotches of tissue that we saw there. What have we learned about the Libby disease? It's painful. Usually those big blotches of tissue that you saw there, they don't cause any pain or very, very little pain. It's been a handful of papers in the medical literature that talk about pain in asbestos-related disease. In Libby is one of the most important features of the disease. It grows fast. In regular asbestos disease, people spend years, 10, 15, 20 years, and they barely get worse. In Libby, over 2, 3, 5, 7 years, the people get really, really, really sick. We call it rapid progression. It progresses very, very rapidly. It's associated with damage of the pulmonary function. When you do a test of pulmonary function, where you put the people to blow, those people with those big blotches of tissue, their lung function is almost always normal. It's almost always preserved. In Libby, that little thing around the lungs causes the lungs to collapse, and you cannot breathe deeply. You cannot take a deep breath. It's associated with markers of what we call inflammation and tissue damage, and this is what you've been hearing about, the autoimmune disease. So there's inflammation that is causing this disease, and that is where we think is going to be one of the answers for treatment that you were asking. We're hoping that we can figure out what is inflammation, how to attack this inflammation, how to stop it, and how to stop the progression of disease. It's generally not recognized because the doctors are not looking at it, and the worst thing is it can kill you. You know, there's been cases that show that this type of deceiving thickening, of very, very tiny thickening of the lining of the lung can kill you. We call it lamellar because it's very, very like a little shade around the lungs. So it's like a lamellar part of the lungs. And that's what I wanted to show you. And what I wanted to say is, we've been doing this for many, many years. We've seen it. Dr. Yankelevich, Dr. Flores, myself, Dr. Black, of course, Dr. Morissette, all the docs have seen Dr. Molin, all of us have seen this disease, and we know it's real. Don't let any people saying it's not real. Please, we want to really, really stay here and say, this is a real condition, this is happening. The fact that many docs don't believe in that is because they don't want to believe. But definitely this is real and this is happening. Yeah.
One thing I'd like to point out is that as a doctor, when you're seeing a patient, you just don't look at a scan and say you have this disease. You got to put the whole picture together. So you have a patient who comes with short of breath, who has pain, you're suspicious of this, the scan just confirms what you see. It's just common sense. It's not you have this. Problem is, common sense ain't too common, right? But if you see a patient that behaving like a duck, quacks like a duck, it's a duck, right? These are just confirmatory things that help you figure out what's going on with that live patient that's in front of you that's suffering.
Have you seen a lot of this pleural thickening in New York City after 9/11?
9/11? No. The answer, so let me backtrack. The disease we've mostly seen in New York City is the classical asbestos disease, the one that I showed you in the beginning. And it takes a long, long time for it to show. To my knowledge, there's really, nobody's looking into Libby type of disease in the 9/11 that I know, this type of pleural thickening. I have to say, honestly, I filed for a grant many years ago to try to do that, and it was not accepted. And you need funds to do research. But we know that the first 32 floors of one of the towers were covered with asbestos, and much of that asbestos was vermiculite. So there has to be, but we haven't seen it. But we may not be looking for it, and this goes like that.
Have they been tested?
No, they get CAT scans. Yeah. We have Dr. Molina is one of the experts in World Trade Center disease here.
Hi, I'm one of the doctors who established the World Trade Center program, so I've been studying it for about 24 and a half years. The dust from the World Trade Center that was collected showed about 2.4% asbestos, but most of it was chrysotile. It actually wasn't Libby amphibole. And in fact, when they looked at people's lungs in the few months afterwards, they were able to find asbestos fibers that were uncoated, meaning they were new. And they were also chrysotile. So most of it came from the building materials that were used either to line the elevators, because even though it was stopped up to the 40th floor in the North Tower in terms of the spray on asbestos, the elevator shafts throughout both towers had asbestos, but all the building materials, like any of the drywall that may have had residual joint compound, was going to be chrysotile based. So that's what we're seeing. We are beginning to see some asbestos-related disease in World Trade Center folks. Some of those folks may have had previous lives in construction, because we know many of the folks in our program are construction workers or firefighters who are at risk for asbestos exposure. But we're looking to see if the rates are going to be higher than we would have expected. But we certainly haven't seen the typical Libby pleural findings among the World Trade Center folks yet. It's been more of the traditional asbestos.
So chrysotile is the classical asbestos, the one that will causes those big blotches of tissue that I showed you before. Libby is a different type of asbestos. Thanks. Okay, thank you.